Welcome. Well, let me just get the right screen up here. All right, so I'm gonna, take the next little bit of time talking about an active approach, which is a little bit newer in, I think, the brain injury world, especially in sport-related concussion. And I have no conflicts with this presentation. But what we're going to talk about are some of the current best practices in the evaluation of concussion. We'll debate the merits of rest and activity in concussion management, describe treatment and rehabilitation strategies that can be effective for patients. And then lastly, over the last month, there's actually been a couple of papers published that have provided actually some evidence about how the pandemic has impacted concussion management, concussion clinical care, specifically from sport concussion clinics. But I think it'll give us some good insight as to ways that we could probably move forward. And it'll dovetail very nicely on some of what Dr. Gupta presented. So previously, this is how we managed concussion. And my world is the sport concussion world. So we are often dealing with patients who are highly motivated to return to their sport, to get back into participating at the same level that they were before, and are often criticized for not reporting their concussions and not necessarily being honest with symptoms. But I think in some cases, this model perpetuated over other areas of concussion as well, not just the sports world. But the patient would sustain a concussion, and the advice given to them was, well, we don't want you to do anything until your symptoms go away. And then in the sport world, once they were asymptomatic, we would put them through a graded return to play progression that would start out with some light exercise and eventually get them back into full sport participation. But it was very passive. There wasn't a lot that was really happening. And part of this, I think, is that we approached concussion using a biomedical model. And in a biomedical model, health is really defined as the absence of disease, or in the case of concussion, asymptomatic, and then the resolution of structural and physiologic disruptions. Well, with most sport concussion, there are no structural dysfunction or structural impairments, but we do have what we would consider functional impairments that we would often measure on balance assessments and cognitive assessments. And in the sports world, we would do preseason testing, and we would see, are they back to their baseline? And the asymptomatic and back to baseline were kind of, I think, a surrogate or a proxy in some way of health in these patients. And that's really what we looked at. We have come to learn, thankfully, that not all concussions are equal. Patients present very differently. Their response to the injury is different. Their symptoms are different. I think now, from a patient-centered approach, their goals and what they want to be able to do after the injury are also very different. And that has really led to a number of papers really trying to, I think, explain and help clinicians understand the biopsychosocial model, or in some cases, the neurobiopsychosocial model with respect to concussion and brain injury. And these are contemporary alternatives that help clinicians better understand what their patient is experiencing, what their patient brings to the injury, and doesn't look specifically at that biological element alone, but also includes psychological and social dimensions of our patients' lives. And this is a really nice paper by Jana Register-Mihalek, who is a sport concussion researcher out of North Carolina, who does a lot with public health models and concussion. And when we look at the biopsychosocial model, there's a lot of things we need to take into account when we're assessing patients. In the sport concussion world, athletic trainers and physicians do a really good job with symptom evaluation, assessing cognitive function, balance function, vestibular function. We have tests we use on the sideline. We have different ones we use for follow-up exams. There's a lot of good validated information, but most of what we do fits into that left box, that biologic box. We are starting to see better studies looking at autonomic nervous system dysfunction, and as a result, the use of early exercise to improve outcomes. And that's part of what I'll get to in this presentation. But where I think we're still lacking a little bit is how we both assess, manage, and treat patients' psychological and social elements. There's some good evidence suggesting that anxiety and depression in patients both prior to the injury can be exacerbated, as well as can be the result of an injury in patients who may not have a predisposing mental health condition. We also need to look at things like peer support, family support, whether or not the patient is getting cognitive behavioral therapy or other treatments. And then from a social standpoint, the sports world is very easy to kind of look at this peer dynamic. Oftentimes our athletes are a member of a team, at least in a lot of the high risk sports for concussion. And so there's kind of that automatic support group. Well, we can think about it in patients even outside of sport concussion. You know, they have their work friends, their family, their social groups, and all of these peer interactions are important and can certainly be hindered in the way that we might manage these injuries. So if we want to look at how we might manage or even approach concussion right now, it should look something a little more like this. First, we need to have a good understanding of some of the risk factors that our patients may bring with them to the injury. This could be a past history of concussion that we know actually predisposes them for subsequent injury and a prolonged recovery. It could be other medical history elements. A lot of comorbid mental health conditions can actually protract recovery. And it could also be the mechanism of injury. Motor vehicle accidents oftentimes have, a greater psychological component. The fear of being injured again can certainly be an element of that, compared to sport, compared to, some other mechanisms. So before the concussion even happens, every patient is already different. Once the injury happens, we are oftentimes in athletic training able to assess some of these things right at the time of injury. And sometimes our patients don't tell us and we see them a couple days after injury and we need to assess them at that point. But oftentimes we assess what we think of as this four-legged stool. We have various symptoms assessments we use. We assess cognitive function in a kind of a down and dirty format, sometimes with some just very quick mental health status type questions. And we can do it in computerized neurocognitive assessments down the road. We can also refer to neuropsychology and use them for our cognitive assessment component. We have balance assessments that range from, can you stand on one foot with your eyes closed, to these instrumented systems that use virtual reality and all sorts of other elements. And again, the timing and when we might use these is going to differ. And then lastly, the newest kid on the block, I guess you could say, is really a good understanding of ocular, motor, or vision function and assessing that. So we often assess these elements. And then what we should be doing is using the information we're gaining from our patient assessment of symptoms, as well as our clinical adjunct assessments, and identifying what we're going to call a concussion profile, a concussion subtype, concussion trajectory. There's a couple different taxonomies that I'll go over that kind of classifies patients into a type of concussion because they're not all the same. Then once we have that profile, we can choose our treatment and rehabilitation plan to match the profile. And then once we figure that they're at the point that they are ready to do a return to learn program for school, a return to play program for their sport, we work them through that. So it's adding kind of these other elements in the middle where instead of saying, just sit down and don't do anything, let's do things, because we know, at least from some of the early evidence, that the outcomes are much better. And so in our assessment, we can use a symptom inventory, a symptom interview. There's all sorts of different scales that we can use. Like I said, our cognitive function can be as simple as, I want you to remember these 3 words, to very formal referrals to neuropsychology. balance and ocular motor. And then kind of my soapbox is I think we also need to be assessing patient report outcome measures. If we want to know what's important to the patient and how the patient feels, we need to be asking the patient. And so as an example, some of the tools that we use in athletic training and sports medicine are the post-concussion symptom scale. One of the computerized cognitive batteries is called IMPACT. A tandem gait test, or kind of like a tightrope walk test, is actually very useful both in clinic and on the sideline. We have a series of ocular motor assessments called the vestibular ocular motor screen, or the VOMS, that includes assessment of smooth pursuit, saccadic eye movements, convergence, vestibular ocular reflex, visual motion sensitivity, that has been validated for use both on the sideline and in clinic. And if I'm doing these assessments and my patient is complaining of dizziness and balance problems, maybe their cognitive function seems okay, but their tandem gait is impaired and they have some issues with the vestibular ocular motor exam. Well, I might want to add a dizziness handicap inventory, because I'm thinking in my head now, I'm going to be classifying them in a vestibular or a visual concussion profile. And so this is just kind of one way that we start to figure out what type of concussion, for lack of a better word, our patient might have. And just to give you an idea of some of the tools that we use, this is a graded symptom scale. Where every time we assess the patient, we are asking them to usually rank their symptoms on a scale of 0 to 6, 0 being I don't have it, 6 being it's the worst headache of my life. And oftentimes we look at the bottom where it says total symptom score, and we get a sense, and athletes tend to learn, well, it's going to need to be 0 before I go back to play. Well, I think that in and of itself is a bit of a misconception. There's excellent studies out there that show that normal adolescents have symptoms, right? I have a high school freshman and a high school junior, and they are probably fatigued almost every day. And my daughter can be irritable a lot. So I don't expect them to be at 0 all the time. But what we can do as clinicians and folks who are advocating for individuals with brain injury is, as we look at these, let's try to group them together. So fatigue and trouble falling asleep, maybe our patient is having some sleep issues, so we need to address those first. Maybe it's the irritability, sadness, nervousness, and feeling emotional. So we're talking like mood anxiety symptoms. Well, we would treat that very differently than we would a patient who is primarily having sleep-related issues. And so when I teach this to our students, this is just a different symptom scale, but another commonly one used in sports medicine. But if my patients are mainly complaining of a lot of dizziness, a little bit of blurred vision, and some balance problems, I can kind of group them in this physical or somatic domain with a visual vestibular problem. And then I would purposefully choose what patient-oriented outcome measures fit with that. Now, if my patient tended to highlight symptoms that fell into the emotional, I wouldn't want to give them a dizziness scale. I would want to give them an anxiety scale, a depression scale, a profile of mood states, or some other patient measure that really fits what they're complaining of and what seems to be important for them at that point in time. The other thing that I think is important with concussion is that it can be very dynamic. That maybe, day 2, 3 after the injury, headache is the most significant symptom that they have. But by day 5 or 6, it's something different. And so we need to be able to adjust, and we need to be able to advise and counsel our patients that these symptoms can change over time. If you start out with headache being your major problem, it might not be that next week. We need to figure that out, which is why I think having a team, having advocates, and having clinicians who are hopefully going to see these patients a little more regularly can be helpful. So when we think about these types of concussion or profiles or subtypes, these are some of the common ones in the literature: a cognitive, mood anxiety, sleep, cervicogenic migraine, vestibular, ocular motor, and physiologic. Some of the classification taxonomies are very simple. This is one out of the group at the University of Buffalo, along with Dr. Ellis, who is up in Manitoba. they'd have 3 different classifications: vestibular, ocular, cervicogenic, and physiologic. And you could see how they define them and then what kinds of treatments are recommended for patients who primarily have that particular classification. The Coach CV taxonomy has more categories. They include an affective or emotional category, as well as a cardiovascular category for patients who tend to have what we consider autonomic nervous system dysfunction that does not allow them to exercise to maximal capacity. And so this one's expanded a little bit more, but you can see in the second bullet that the directed treatment type for each of these is going to be specific, and it does differ by how we might categorize our patients. This categorization is from the Center for Disease Control and Prevention. This is a series of projects that were commissioned to Dr. Lumba Brown out of Stanford. And in their review of the literature, they deemed that there were 5 subtypes of concussion and 2 what they called concussion-associated conditions. And that really meant that the sleep disturbance and the cervical injury, you could see that with any of the subtypes. So you might have a patient who primarily has a headache migraine subtype who might also have a cervical strain and some cervicogenic issues. So a lot of times these associated conditions can accompany any of the profiles. And the last one I want to highlight is actually my favorite because it's kind of colorful, but I think as a student learner, as well as a clinician, it kind of puts all of the pieces together in one figure. This is from the American Medical Society for Sports Medicine. So these are our primary care sports medicine physicians. And if you focus in the center, in the gray oval, it says concussion symptoms. And then in the first circle, it lists all of the different symptoms that you saw previously on one of those graded symptom scales. But it has started to categorize them into these 6 different clinical profiles: headache, migraine, anxiety, mood, fatigue, cognitive, vestibular, and ocular. I think there's a couple of things that are critical. The first is this is like a crazy Venn diagram. So there is so much overlap that we need to consider. We don't just pigeonhole our patients into one of these without thinking of the neighbors and that they could have some associated complaints in some of the other areas. It also allows us to perhaps identify what we would consider a primary concussion profile, a secondary concussion profile, and in some cases, a tertiary concussion profile. As we move out towards, I guess, like the petals of the flower, you can see what we would expect on our physical exam findings. So for example, a patient in that cognitive profile, their physical exam, neurologic exam, for the most part might seem normal. They might not have a lot of neurological dysfunction. They will display some confusion, probably some disorientation, and then might have poor performance in various cognitive assessments. So then we can focus our targeted treatment on academic modifications if they're a student, perhaps formal neurocognitive or neuropsychological testing, followed perhaps by cognitive rehab if that seems to fit the test findings. And that's going to be a little different than, say, our patient in our ocular profile, where their physical exam, we might actually see some impairments, perhaps in near point convergence or accommodation, pursuits, saccades, symptom provocation with a lot of those ocular movements, but they'd probably check out fine on some of the cognitive assessments. And so our targeted treatment would be some type of ocular rehab, some vision training, perhaps even using, on here they have lens changes, so perhaps a consult with an optometrist or an ophthalmologist. So again, it really just depicts, I think, that these are not all the same injuries and that we need to really look at each patient individually. The last thing I want to highlight is the gray kind of large circle of words that surround the entire diagram. And these are 4 general recommendations that clinicians should take into consideration for every patient with a brain injury. The first is that we need to monitor for exacerbation of pre-existing conditions. Again, what your patient brings into the injury is going to affect their recovery. The second is we need to counsel regarding expectation of recovery, or engage in what we call anticipatory guidance. We need to be able to, we might not be able to give our patients the answer to the one question they ask all the time, which is, when can I go back to play? Or when can I go back to work? Or when can I go back to school? But we should be able to give them some expectation. Do they have a lot of comorbid factors? Do they have a really high initial symptom score? Well, those things kind of combined could dictate a prolonged recovery. But again, if we counsel them on how we're going to help them through this, that can certainly be beneficial. We also need to educate them on proper sleep hygiene. Everyone's symptoms are going to get worse if they're not sleeping well. So let's try to ensure that sleep is managed. And then lastly, and kind of the newest, I think, treatment area that we're seeing with concussion is the use of early subsymptom threshold aerobic exercise. Getting patients on a stationary bike, having them walk in their neighborhood. We all know that exercise is good. It probably saved a lot of us during the pandemic that we could even just go and walk around and get out of our houses for a little bit. But there is some really good evidence looking at the effectiveness of aerobic exercise. So what, from a concussion standpoint now, we have our acute management. This subsymptom treatment and rehab area is really where we're going to focus. And for those anyone who sprained an ankle or had a orthopedic surgery of some sort, we kind of go through these phases, the protection phase, the deficit management phase, and the return to sport or activity phase. In the protection phase, you might be in a cast or a brace. In the deficit management phase, we look at your range of motion, we look at strength, and we try to improve that through some kind of therapy. And then we get you back to doing what you want to do. Well, with concussion, it's the same concept. It's just the deficits that we're going to manage in that middle circle are different. It could be cognitive dysfunction. It could be visual dysfunction. It could be vestibular dysfunction. And it could be a combination of those. So we might not have you lifting weights and, that sort of thing. Our exercises are different, but the intent and the process is still the same. And so we need to balance these concepts of rest and activity. We published a systematic review a couple of years ago with some colleagues in our medical school. And we found that moderate physical and cognitive rest could facilitate recovery during the initial days after concussion. So, the day after the injury, we don't want anyone going and running a marathon. But we don't want people not doing anything for 1 week, 2 weeks, 3 weeks. So a couple of days of rest are really what is recommended. And in the sports world, it's about 24 to 48 hours. And then let's try to get people somewhat active, not playing their sport, but again, just walking, sitting on riding a stationary bike and that sort of thing. And to do that, we need to look again at our patient as an individual. We want to avoid things that are exacerbating for that patient. It's not a cookbook approach. Can they tolerate light aerobic exercise? If so, let's get them doing it. Can they read for 20 minutes without getting visual symptoms and a headache? Yeah, let's get them doing it. Can they go to school? Yes, let's get them doing that. Two of the biggest, I think, issues over the last probably 10 years is this pendulum swung at one point. And we were telling kids, don't get on your computer, don't text your friends, don't. Basically, go sit in a dark room. And these were physicians that were giving this advice. Well, I don't think anyone's really been hurt from texting unless they're driving. And for our adolescents, that's their prime source of social interaction in some way. So now you want to take that away from them right after you've told them you can't play football for a while. So we need to, again, balance it and ensure that what we're doing allows them a little bit of cognitive and physical activity, but does not increase their symptoms. So we have some good guidelines from our international consensus statements on concussion, looking at treatment, that these should be individualized, symptom-limited aerobic exercise programs. We should be using targeted therapy And these should be collaborative approaches with a multidisciplinary healthcare team. Now, in our patients who have what we'd consider a prolonged recovery or persisting symptoms, we want to probably kind of go back in and do a more thorough multimodal clinical assessment, and then continue to individualize their targeted treatment. So from a treatment standpoint, we can do all sorts of different things. It really depends, again, on the patient's clinical profile, on their adjunct test scores, and on their goals and what they're trying to get back to. For the sake of time, I'm going to skip some of that, but some of what we want to focus on for the different profiles. Our patients in the cognitive fatigue, we want to regulate sleep, stress, diet, and mild exercise. That sounds something like we should all be doing anyways, but that's where we really want to focus and educate. Vestibular rehabilitation, vision therapy for our patients in those particular profiles. In those in the anxiety and mood, oftentimes they do have an associated vestibular issue, so we want to rule that out and treat that if needed. We want to try to get them to be doing some physical activity, ideally with a friend, to get that social engagement and interaction, and we want to regulate sleep. The only one we might want to treat pharmacologically could be those in the post-traumatic migraine category, where they might need a short-term migraine medication just to kind of help settle things down. And then those in that cervicogenic type category, range of motion, manual therapy, a lot of what we would do in physical therapy, athletic training, posture education, soft tissue mobilization, to help kind of calm that down. Now, regardless, we need to teach our patients about sleep. We want to address these first. We know that individuals who've had sleep disturbance related tend to have greater symptom burdens, lower neurocognitive scores, just that general malaise feeling. We want to instill good sleep hygiene in our patients. The two links at the bottom have some great patient handouts. And I'm happy to share these slides with Carrie, and she can get them to anyone who might want them. But they're great handouts to have to give to patients. We can do some more formal assessments in our patients who might be having sleep issues. My Garmin watch tracks my sleep. I'm sure a lot of us have something like that, but we could do more formal sleep studies, have patients do sleep diaries, or use sleep-specific patient report outcome measures. From an active rehabilitation standpoint, these programs usually have a lot of components. Again, patient education is a key, aerobic exercise, some balance activities, mental training and visualization, as well as some sport-specific skills. And we already hit on the subsymptom threshold aerobic exercise as being a key element for all concussion patients. And the reason for that is exercise is good. We know that exercise is beneficial for both physical and psychological health. Studies have identified improved cognitive function after TBI in patients who exercise. It can help resolve symptoms. It makes us all feel better from a mood standpoint. And then even physiologically, those little rats that run on those wheels, they actually do quite well. And some studies have shown improved neuroplasticity, cortical connectivity and activation, as well as improved regulation of cerebral blood flow. And some of what we know from the rat model studies with concussion is that after that initial impact, our cerebral blood flow decreases. And the problem with that is the blood flow is where our brain tends to get glucose from. So we need more glucose to promote healing, but our blood flow has actually decreased, which causes this mismatch. And in the sports world, we call that the period of vulnerability, where we definitely don't want them to take another hit to the head because of the potential second impact syndrome consequences. So exercise is good. Now, how do we want to do that? Well, we can do it formally. There's actually a couple of tests called the Buffalo Concussion Treadmill Test and the Buffalo Concussion Bike Test that are developed after kind of stress testing that we might do for individuals for cardiac assessments with exercise. But we can determine exercise tolerance Some of these tests have actually been helpful in determining differential diagnoses in patients. If somebody has a concussion, they cannot go until the treadmill gets up to 15 degrees. They can't go 20 minutes. They'll stop. If they can get to the end of these treadmill tests, their symptoms are coming from something else. And usually it could be a vestibular issue. It could be a cervicogenic issue. So again, we use it as part of our clinical exam to aid in our differential diagnosis. And then we also use it as treatment. Once we know what our patient's maximal heart rate is, we can go to a certain threshold of that and have them do exercise as rehab or treatment. And the results of some of these initial studies are actually quite striking. The first study looking at early supervised exercise among adolescent athletes used the Buffalo Concussion Bike Test and a low intensity stationary bike protocol. What they found was there was a significant decrease in the number of days that patients had concussion related symptoms. And while not significant, patients who did the early supervised exercise returned to play about 9 days earlier. You ask any high school athlete that you know, if that is important to them, that's like a game. That is a week of football that they got back because they were able to return. Another study, actually a randomized controlled trial, looked at aerobic exercise compared to stretching. And the group that did the early aerobic exercise recovered significantly faster by about 4 days. And they also had, although not statistically significant, a lower percentage who had a delayed or prolonged recovery. This was published in JAMA Pediatrics, and there was an editorial that went with this article. And the author of the editorial, who is a pediatric sports medicine physician who's done a lot of concussion research, called this paper by Dr. Leddy and his group a landmark study that may shift the standard of care. And when I present this to my students, I'm like, yeah, you should have like red lights flashing that you need to pay attention to this. And if you're not doing this, you need to think about how you can start to do this. Subsequently, they've added a third group into some of their protocols, which is just a relative rest group, which is kind of the usual care, don't really do anything. And again, the patients who do the sub-threshold exercise take significantly shorter period of time to recover, and also have a significantly smaller percentage of patients who have a delayed or prolonged recovery. So there has been probably in 2019, 2020, and 2021, at least 3 systematic reviews. When everyone's research got shut down, I think everyone just started doing systematic reviews that have looked at this concept of aerobic exercise for concussion and TBI. And the findings are pretty striking. They're pretty consistent. That these programs are effective to decrease symptoms. They are safe. There are limited adverse effects when they're done supervised, both in the acute setting and even in patients who might have persisting symptoms who really were kind of in the do nothing category. Even if we get them doing some exercise later, that's actually good. Some of the other exercise interventions that we want to do include using academic support in our patients as they return to school. Some general adjustments that we want to consider. The last thing we want is a student on a school bus that could be too busy of an environment, too loud. So we might need to modify that. A lot of times we need to work with the teachers and the school nurse and the counselors to try to come up with a plan that balances rest and mental exertion. So they might need to take some rest breaks in the office. We might want to give them a hall pass so they can change classes when it's quiet. If anyone's ever walked in a high school hallway, that's not exactly an environment that you want to be in if you have any symptoms at all. We might modify their schedules or their types of assignments, and then prioritize work and really only have them do things that is essential to, again, allow them time to heal. And then we can look again at their specific symptoms, and we can now try to identify certain academic adjustments that are going to help a patient who's experiencing certain symptoms. And I'm not going to read through all of these, but again, it's taking an individualized approach. It's looking at our patient's symptoms and then deciding how we're going to treat or manage that based on what their primary concerns are. Because not everyone needs every single adjustment. Now, if we look a little deeper into some of the other clinical profiles, you know, when we think about something like headache, there's usually a lot of follow-up questions that we want to ask our patients. And the OLDCART acronym is kind of a good way to remember what we should be asking them to try to get more detail. And then once we have these kinds of questions answered, depending on the type of headache that our patients have, our treatment could be different. Those that are complaining more of a cervicogenic type headache are going to benefit more from manual therapy techniques, education and treatment, postural correction, maybe some breathing exercises, some other modalities, whereas those patients that are in that migraine headache classification might actually benefit from migraine medication, as well as vestibular rehabilitation, because there's often a vestibular component to some of the migraine symptoms. Those with our cervical spine issues, we really, again, want to try to focus on stabilization programs, on manual therapy to really try and decrease the symptoms associated with the cervical spine. Probably one of the most difficult areas or profiles to manage is the mood disturbance, mood anxiety. We know that concussion can result in a lot of emotional concerns. And so this is where our multi-dimensional, multidisciplinary team comes into play, where we could use psychologists, psychiatrists, cognitive rehab, other healthcare providers, some cognitive behavioral interventions, in some cases, mood stabilizing medications, but then just trying to teach again and educate where we can structure their environment, try to understand the stresses our patient might be having, allowing time with teammates, and then doing some active treatments which could reduce stress. Carly Elmer is one of our alums from our Doctor of Athletic Training program, and her final project was a critically appraised topic looking at cognitive behavioral therapy for concussion in patients with persistent symptoms, and found that grade B evidence exists that it's actually beneficial or more effective than usual care. And other studies have found similar things related to both counseling and cognitive behavioral therapy. With respect to dizziness, again, we need to ask a lot more questions because dizziness to one person is not necessarily the same to another. And once we have those questions answered, we can think about vestibular rehabilitation. And these exercises are usually done with a vestibular physical therapist. Some of the other vision exercises, occupational therapists work with as well. Audiologists can play a role in some of the vestibular assessment and rehabilitation, and some of the very basic exercises in regards to gaze stability could be done by an athletic trainer in their athletic training facility, since they see patients quite regularly. Our rehab strategies for vestibular rehab could be using adaptation exercises, substitution, or habituation. And some studies have really found that vestibular rehab after concussion, using very basic exercises such as our gaze stabilization, where you are looking at something like your thumb and just moving your head back and forth to a metronome, along with some simple balance exercises and canalith repositioning or like an Epley maneuver, actually had a lot of good outcomes related to decreased reports of dizziness, improvements on patient report outcome measures, as well as functional balance measures. And again, these are just some other studies citing kind of some of the benefits of vestibular rehabilitation in various patient categories of concussion. And then we can, get a little crazy. Oh, and it's not going to play for me. Sorry. In this video here, This is actually a stand, and these lights will flash. And so this individual is hitting a light that flashes. Then he has to return and kick the soccer ball to the therapist. Then he has to run to this side and hit whichever light is flashing here. So we start with these dual tasking element. Oh, is it going to go now? Maybe. So this would be a great exercise for a soccer athlete, right? It's right up their alley. It's exactly what they would be doing. I'm going to apologize for the music on the next one. This would be for, say, a basketball individual. And having the net at the end is kind of a little bonus for that particular individual. But the more we can make it related to their individual sport, at least in our setting, the more relevant it becomes. If you were working with a military population, you could have these type dual task activities be specific to return to duty type strategies. If a patient who's in a work environment in a factory setting, again, we could do all sorts of different things. From a visual dysfunction standpoint, visual dysfunction is very common after traumatic brain injury. It needs to be evaluated and it needs to be addressed. And one area that we started talking about a little bit more with respect to concussion, especially in our adolescents and our college age individuals, is driving. I mean, anyone who's got visual symptoms should not be driving anyways, especially these novice drivers. And so we've kind of started to include return to driving recommendations in with some of our educational materials. When is it okay for them to perhaps get behind the wheel? There's actually some good evidence from studies, mainly out of the University of Georgia, that's used driving simulators that patients with concussion kind of mimic drunk drivers in some ways on these different driving simulation activities. And so these are often what our patients will complain about. Getting tired when reading, they get dizzy if they turn their head quickly, they might see double, their depth perception is off. Hard time paying attention in class, hear this from adolescents all the time. Lights from computers and phones can be a problem. Dizzy and disoriented tying shoes when they're kind of putting their head down. So there could be a little orthostatic hypertension going on with it. And we know that from the sport concussion world, about 30 to 50% of patients have some kind of ocular motor deficit. Convergence insufficiency, accommodative insufficiency, and saccadic dysfunction are the three primary ones that we tend to see. And for our patients, convergence insufficiency looks like this. It might look a little blurry, but for the patients that might have, significant convergence insufficiency, it's kind of that bottom line. And thinking about an individual trying to read like that while keeping up in school is certainly not going to be helpful if we're not doing something for them, both from a therapy standpoint for the vision dysfunction, but then also from an academic management standpoint to help them get through the school day. And so we can look at different vision therapy strategies, optical devices, and then some vision therapy with optical devices. There's a lot of different things that we can aim to do where we want to improve their ability to scan, their smooth pursuits and tracking, making sure their eyes are working together. And then we can get them into functional activity. So we can start all of these with our patients sitting in a chair. Well, once they can do that, we can have them do it standing. Then we can have them do it on a piece of foam. Now we're getting into some of the dual tasking, because eventually, if I'm dealing with a wide receiver who needs to be running down the field at full speed and turning his head, I want him running on a treadmill where I can be doing some eye tracking movements and all sorts of various things to ensure that he is really ready to return to that sport and that activity. So really, again, understanding what our patient's end goal is important. Vision therapy has been shown to be very successful. Many have improved symptom reports after therapy, improvements in vergence, accommodative insufficiency, and saccadic dysfunction. Both a successful outcome and the percentage improved are helpful. And then again, from an education standpoint, we should all be able to provide our patients with some information about tools that are already built into their computer. You know, how do you increase the font on a web page? How do you change the brightness on your screen? These are very simple fixes that could help patients who have some of these visual dysfunctions. More so for the therapists in the room, these are a top 10 must have list of different tools. And I think one of the things that's nice, and I discuss with our students, is that you can kind of mock up a lot of these by just going to your local craft store. So wolf wands we use for a lot of different things. Well, that would be a knitting needle with a little foam ball on it. And so you don't need to have a lot of expensive equipment or tools. Heart charts you can get off the internet. You can buy or make Brock strings for convergence insufficiency exercises. I guess it would take you a while perhaps to write letters all over a baseball or a softball, but you could if you didn't want to or didn't have funds to buy a Marsden ball. So there's a lot of different tools that we can use. And then when we think about progressing our patients, this is where I think rehab can get fun. We're not doing the same thing all the time. We can change our target. We start with static head and target, but then we can have them move the target, keep their head straight. Then we can have them move everything. We could start them seated and get them to standing to an unstable surface and moving. I think, the background, we could have them just staring at something on the wall. And this, again, craft store, all different kinds of scrapbook paper, right? You get plaid next, and then you get some funky colors, and then you put little letters on them, and you can do all sorts of things. There's also some great computer programs that can be actually used for saccadic eye tracking, different videos that are certainly not expensive to be able to make some things kind of fun with the patients. I have a series of videos that we can use to train saccades or smooth pursuits. And, one version is a baseball, the other version is a basketball. So again, I can tailor what I'm doing to the type of patient that I'm working with and his or her sport to at least try to make it somewhat representative to them, somewhat fun. If they have to track a basketball and they're a basketball player, if they might, buy in a little bit more and, think that it's actually okay to be doing the rehab. And then lastly, from a skills, we start isolated and then we want to get integrated. It doesn't matter if it's a sport, if it's military duty, if it is, someone's job. We don't do things in an isolated manner. So we need to be able to integrate multiple systems and multiple tasks at the same time. So putting it kind of all together again, and when would we transition patients from kind of this treatment rehab to what we would consider our formal return to play progression? And these are the criteria that we often use. They are back to school full-time without academic adjustments. They do not have symptoms at rest. They might have some symptoms that do, but they don't increase a lot with activity. It's still sub-symptom threshold. And if they were put on any medication for their concussion that they were not on prior, we want them weaned off that medication. So for example, a patient who maybe does not have a migraine history, was never on a migraine medication, was put on something for migraine related symptoms after the concussion, we want that to resolve before we consider they return to play. Now, if we had another patient who perhaps was diagnosed previously with ADHD and was on Ritalin or another medication, we don't want them going off that. We still want them to maintain. And again, this is where the communication with primary care providers and other specialists are going to be important. Once they kind of hit those elements, now we transition them from what we'd consider a treatment rehab program to our graded stepwise return to activity program. And that would be this step that would look something like this. Where we start again with some light exercise, some static balance, some vestibular ocular rehab, and then stable head vision. And we continue to progress them. Usually we progress about one step every 24 hours. And the goal is to then, if they're doing that light exercise and transitioning from their rehab, then we'd want to make sure that we're doing some sport specific activity. you know, if they are a goalkeeper in ice hockey, we need them in the net. We need them skating. We need them doing all sorts of things. If they're a swimmer, we need them in the pool. We might not have them initially diving or doing flip turns, but we need something in the pool. We eventually get to what we call a non-contact practice, where they're doing absolutely everything, but in a safe manner. And then before we let anyone return to game or competition, we want to see them in a full contact practice, make sure that everything looks good, they feel good, they're confident in their return before we return them fully. So a lot of this was impacted during the pandemic because sports shut down. And so we certainly were not seeing a lot of concussions. I'm in the middle of a study aiming to validate a patient report outcome measure for concussion in adolescents. And every single site that was in the study was shut down. So we had a little bit of downtime, but so did everyone else. And so some research groups actually really started to look at how did COVID affect their clinic, their patients' recovery, as well as how they were managing patients. So this is out of the University of Pittsburgh, and they're probably one of the biggest sport concussion centers in the US. They actually saw a decrease in the number of patients seen by about 40%. The time to clinic presentation increased by about 20 days. They saw a 60% decrease in patients who came from a sport-related mechanism, which is not surprising because sports weren't happening. But if you look at the other mechanisms, recreational non-sport, motor vehicle accident, fall and accident, all of those increased from their pre-pandemic. They did 0 telehealth visits prior to the pandemic, and then we're doing about 10% telehealth visits. And this transitions to another paper. This is by Melissa Womble, who's a neuropsychologist. And this is a great theoretical paper about telehealth for brain injury. And this, I think, sums it up very nicely. There's certainly a lot of benefits to using telehealth, increased access to specialty care. I think especially in rural settings, this could certainly, I think, continue moving past the pandemic. In Arizona, if we think about it, all of our primary concussion centers are in the Phoenix area. There's a group in Tucson and some physicians in Flagstaff. But once you move beyond that, our concussion specialists are really lacking. Reduced time and commitment for patients. They don't need to commute, reduction in clinical costs, improved engagements for patients who otherwise become symptomatic in the office. And oftentimes from a patient comfort standpoint, they'd rather be at home. I mean, the whole medical center anxiety can also play a role in increasing symptoms. Obviously, there's some challenges and limitations. Everyone's got to be educated on how to do this. There could be some distractions for patients. We need to be aware of interstate licensing laws and reimbursement issues, which were brought up in the past talk. And then obviously technology can be a problem if patients don't have access to technology, but perhaps there could be kind of a bridge mechanism where health centers in some of the rural areas are able to communicate with our specialists. And so the patient is just driving to their local provider instead of 3 to 4 hours to the valley. And then they hit on some potential solutions on where we could be going as different professions, as advocates in the healthcare industry as well. And then the last study actually looked at in-person versus telehealth visits for concussion. This was again from a concussion specialty clinic. What they used was what they called a therapeutic alliance score, which is a validated scale that was given to both patients and caregivers. And then they used patient satisfaction scores. And overall, both patients and caregivers indicated they were highly satisfied with the telehealth or the in-person visits on a number of different subscale elements related to that. For the patients, there was no difference in the therapeutic alliance score. And the therapeutic alliance score really gets at their perception of their care. And then the mean ranks for caregivers were slightly higher for the in-person as opposed to the telehealth. So I think there's certainly some opportunities in how we could see telehealth moving forward. I haven't seen it published yet, but I did see Scott Burkhart, who is a neuropsychologist in, I believe, the Texas area, had presented on a particular study where they were looking at doing the VOMS, that vestibular ocular motor screen, in a telehealth format. And they were looking at reliability and validity of that assessment tool. So going beyond just perhaps a visit, but actually doing assessments in a telehealth model. And they found that it worked very well for them. And so again, I think additional opportunities moving forward. So in conclusion, hopefully take-home points are that concussion can be treated. We need to use a symptoms-based approach where we are identifying and then treating our concussion profiles using multidisciplinary teams. And then think of it, as a progression. The treatment just seamlessly will flow into the return to school, the return to work, the return to duty, the return to sport. So we might have a couple minutes for questions, but Carrie and Kristen, I'll turn it back over to you.
Yeah, that was some fantastic information. We do have one question from the phone. Have you seen an increase in stress and anxiety around students, and does that play a role in concussion recovery?
Oh, yeah, I think across the board, we've probably seen an increase in all sorts of mental health conditions and symptoms, not necessarily perhaps a diagnosed depression, but more depressive symptoms among adolescents. There's been so much uncertainty. If you think of like last year, they were in school, they were out of school, in school, it was kind of one day, and in adolescence, that's a lot of change that I know from my own kids doesn't always go over very well. So I would say that yes, there is probably across the board a little heightened mental health concerns that will certainly amplify in patients, I think, with concussion. I think the other thing in student athletes right now too is they're all dealing with trying to mitigate COVID protocols as well, and that throws an entire level of anxiety, I think, because of the potential to be considered a close contact that could then throw you into quarantine or isolation. And if you did have a concussion at that time, so it's one more thing that the athletic trainers at the high schools are dealing with right now.
Wow. Our next question is really interesting. Do you think a loss of routine played any role in some of those increases in concussions? And I saw this in my neighborhood. I saw kids that rode their bike to school with their helmet on every morning. They had this routine, and then I would come home in the middle of the day and there'd just be like kids on their bikes with no helmets. It just kind of seemed like that structure fell away for some. But this is an interesting question we have. What do you think about that?
I definitely think that could certainly play a role in a lot. I think without organized sport, which are often at least supervised by an adult coach, even if they don't have on-site medical provider, those kinds of activities were replaced with, going to the park and the skate park, or riding like you said, riding their bikes in the neighborhood, that they might not necessarily do in as safe a manner. Especially if mom and dad are sitting on their computers working from home and don't see the kids not wearing the helmet as they leave. But I think just the general disruption of schedules certainly plays a role on a lot of elements of mental health and physical health, that if you add a brain injury on top of that, can be problematic.
We have lots of comments about what great information this was, and a couple people said that they wish this would have been available when they had their brain injury or when their children had their brain injury. Related to something Dr. Gupta spoke about, she spoke about how it was hard sometimes to get that therapy through telehealth when all your brothers and sisters are on Zoom school and your parents are trying to do their job and keep everything going. If treatment fell off or was delayed, or maybe we didn't investigate it, is it too late for treatment? This person would like to know for concussion.
Yeah, I think the short answer to that is no. There are probably some caveats to that. But if you look at just the literature from early aerobic exercise alone, the initial studies that were trying to identify whether that was an effective modality were all done in patients with what at the time, what they were calling post-concussion syndrome. So patients who were having persistent symptoms. It was like, you know, okay, well now let's try this because it doesn't seem like anything else is working. Because it was so effective in reducing symptoms in those patients with the prolonged or persisting symptoms, they started backing up the timeline. And there's some, excuse me, athletic department sports medicine programs that they are putting athletes on bikes day 2 post-injury. It is now like, let's do this early because we know it can be beneficial. But I don't think the answer is that there's any time too late. I will say there's also good evidence from Rosemary Moser, who's another sports neuropsychologist, looking at implementing academic adjustments. You know, now we try to do that within the first week, like let's really help this student. She has studies that show that even if you don't implement anything until 1 month post-injury, as soon as you implement something, you actually start to see benefits. So I would say it's not too late. If folks are having concern, it's trying to find the right, I think, person to kind of quarterback your healthcare and figure out what we need to do and where we need to go.
That's fantastic. And thank you also for showing examples of how some of those at-home treatment modalities can be really inexpensive, that you can do things to complement any assistance you're getting at home.
You're very welcome.
We have, oh, this is a good one. We have one more question around concussions in the senior citizen population. So this is something that we might explore at our professional conference, but there can be a tendency sometimes when someone presents at the ER and they've fallen and they are a senior citizen to just kind of chalk it up to other things related to aging and not really get to the concussion. And now that we have emergency rooms filled with people with COVID, it's probably even worse. Do you have anything to say on concussions in the senior population?
It's a great observation and it is spot on. I think a lot of times when there's fall risk and falls in seniors, the first thing we worry about is the fractured hip and some other orthopedic injury. And a lot of times, you know, that becomes the focus. And so I think from an opportunity or an education standpoint, we need to be doing better with our emergency department providers, ensuring that they are at least doing some kind of TBI screening in those patients. And if they're not, I think it could be, and you know, this might be a great area for you know, the Brain Injury Alliance to focus is just our advocates for our seniors. If you are a caregiver for a senior, you know, if you have you know, a family member who lives with you or you are seeing them, just to be aware that, you know, if they do have a fall, there's other things that could happen. And we definitely don't want to miss anything related to the brain. So, you know, asking the emergency room providers and so forth.
Good. Yeah, that's a great question. And we're always seeking funding for different things that the Brain Injury Alliance can do in the emergency room as far as being part of that referral process. Yep. Any parting thoughts on going into the holiday season, on year 2 of COVID and kind of managing just kind of what to expect or how we can help people going forward and how we can use our voice to talk about concussion?
Yeah, I think just, you know, continuing to spread the word. I mean, because we're in a pandemic and everyone is focused on COVID, it doesn't mean that other injuries and illnesses aren't happening. You know, and I think that can be problematic, that everything else kind of gets pushed to the side because everything's you know, focused on the pandemic. I think it's important that, you know, as certain things start up. So if you're, you know, heading up to Flagstaff to ski, wear your helmet. You know, as the weather gets better here and more kids are going outside, you know, having, you know, just that education on, you know, everything from helmet use to what to do, to recognizing a concussion, and then, you know, what do you do, or who should you see, and just not letting it, you know, it's just a bump. I just got my bell rung. Like, get it assessed and get it managed.
And thank you so much for presenting that research today. We know that everything had to go online and adapt, and it was kind of amazing to see that research also went online as far as recruitment, and it was acceptable now to interview research participants via Zoom. So that was exciting just as well. In November, we're going to actually look at how COVID impacted brain injury research, both private and federally funded. So we look forward to doing that. So thank you, Dr. McLeod. Thank you for joining us. We hope to have you back again soon. This was fantastic information.